Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 350 of our pharmacotherapy entitled Dosing of Drugs in Renal Failure. My next question to you reads, TMJ is a 65-year-old woman with chronic kidney disease awaiting a kidney transplant. She has been managed with peritoneal dialysis for the past 8 years. She presents with a cloudy effluent and abdominal pain. Analysis of the effluent reveals a WBC count of 323 per microliter and gram-positive cacao and clusters on gram stain. The patient has a history of Staphylococcus aureus peritonitis that was readily treated with cefazolin previously. The patient has no allergies, and weighs 52 kg. How should TMJ's peritoneal dialysis-related infection be managed? Gram-positive cacao such as Staphylococcus aureus are common causes of peritoneal dialysis-related infections. The selection of empiric antibiotics should be made based on the patient's and program's history of microorganisms and sensitivities. A first-generation cephalosporin such as cefazolin would be a reasonable choice for TMJ programs with a high rate of methicillin-resistant organisms should use vancomycin. Intraperitoneal antibiotics can be given with each exchange, that is continuous dosing. In this situation, a single 500 mg per liter loading dose of cefazolin is given, followed by a maintenance dose of 125 mg per liter with subsequent exchanges. Antibiotics can also be given intermittently, that is once daily per exchange. With intermittent dosing, the antibiotic-containing dialysis solution should dwell for at least 6 hours to allow for adequate absorption. Cefazolin 15 mg per kilogram, rounded off to 750 mg, is typically given in one exchange. For patients on automated peritoneal dialysis, the dose of cefazolin is 20 mg per kilogram every day in a long day dwell. For patients with residual renal function, e.g., greater than 100 ml per day of urine output, empirically, the dose is increased by 25%. The management of peritoneal dialysis-related infections and dosing of various antibiotics is discussed in the International Society for Peritoneal Dialysis Guidelines. The next case reads, LRS, a 24-year-old man with end-stage renal disease from rapidly progressive glomerulonephritis, is treated by hemodialysis 3 times weekly. He has a 7-year history of generalized tonic-clonic seizures and has been treated with phenytoin. He presents to the emergency department after having had a seizure lasting about 5 minutes. His mother states that he ran out of phenytoin 4 weeks ago. Because his plasma phenytoin concentration on admission was less than 2.5 mg per liter, LRS is given an IV loading dose of fosphenytoin, that is 15 mg per kilogram in 30 minutes. Additional admission laboratory work includes the following: a serum creatinine of 8.6 mg per deciliter, a BUN of 110 mg per deciliter, potassium levels of 5.4 milliequivalents per liter, calcium levels of 9 mg per deciliter, albumin of 2.9 grams per deciliter. 8 hours after administration, his phenytoin level is 5 mg per liter. So my question to you is this level subtherapeutic? LRS has severe renal disease, which will affect the total, that is bound plus free, phenytoin concentration achieved and how this concentration is interpreted. Decreased plasma protein binding will result in lower measured total phenytoin concentrations, and the calculated apparent volume of distribution may increase. In patients with normal renal function, approximately 90% of the measured phenytoin is bound to albumin, and 10% is free. The free fraction of phenytoin is increased to about 20% to 25% in patients with uremia. Because the free fraction for phenytoin is increased in patients with uremia, lower plasma concentrations will produce therapeutic effects that will be equivalent to those produced by higher phenytoin concentrations in patients with normal renal function. Phenytoin is an acidic drug that is bound primarily to albumin. A number of mechanisms have been proposed that account for the decreased binding, including a. decreased albumin concentration, b. accumulation of uremic byproducts that displace acidic drugs from their binding sites, and c. alteration in the conformation or structure of albumin in uremic patients, resulting in a reduced number of binding sites or decreased affinity for drugs. The relevant equation should be used to correct for LRS's altered binding owing to his renal dysfunction and hypoalbuminemia. Alpha is the normal free fraction, 0.1, P' is the patient's serum albumin, and PNL is normal albumin, that is 4.4 grams per deciliter. The factor 0.48 was derived from patients on hemodialysis and represents the decreased affinity of phenytoin for albumin. For RS, a total plasma phenytoin concentration of 5 mg per liter is comparable to 13 mg per liter in a patient without renal failure. Because this falls within the phenytoin's therapeutic range of 10 to 20 mg per liter, his measured level is not subtherapeutic. The factor 0.48 should be used only to estimate changes in protein binding for patients with end-stage renal disease receiving hemodialysis. Data for patients with moderate renal disease are limited, and it is unclear what changes exist in the binding of phenytoin to albumin. For patients with normal or moderate renal impairment, the following equation should be used only if the serum albumin is low. The factor 0.48 should be omitted according to the relevant formula. Fosphenytoin, a prodrug of phenytoin, does not need to be dissolved in propylene glycol, and therefore can be administered more quickly. This offers an important advantage for seizures that must be controlled quickly. In patients with renal failure, the conversion of fosphenytoin to phenytoin was equally efficient in patients with renal disease and healthy subjects. Once fosphenytoin is converted to phenytoin, the impact of renal disease on protein binding is expected to be similar to that seen with phenytoin, and thus the same considerations should be made for patients with renal failure. The next case reads, EFG, a 56-year-old woman, is admitted for a cervical laminectomy. She has a history of chronic kidney disease, creatinine clearance 20 ml per minute, and arrhythmias that are treated with amiodarone. Her admission laboratory values are as follows. A serum creatinine of 4.4 mg per deciliter. A BUN of 66 mg per deciliter. A hematocrit of 34%. A hemoglobin of 12.6 grams per deciliter. After surgery, she complains of severe pain and is treated with meperidine 50 to 100 mg intramuscularly every 3 to 4 hours. 3 days post-operatively, EFG experiences a generalized tonic-clonic seizure. She has no history of seizures. So my question to you reads, what might be responsible for this sudden event? Meperidine is a narcotic analgesic commonly used to control acute pain. It is metabolized hepatically via N-demethylation to normeperidine, a metabolite known to accumulate in renal insufficiency. Although meperidine has both CNS excitatory and depressant properties, normeperidine is a very potent CNS stimulant that can cause seizures in patients with renal failure who are receiving multiple doses of the parent drug. Patients with renal dysfunction given meperidine experience more neurologic effects. Because the renal clearance of normeperidine correlates significantly with creatinine clearance, renal dysfunction can lead to its accumulation, resulting in neurologic toxicity. The normeperidine to meperidine plasma concentration ratio was consistently higher in patients with renal failure, averaging 2.0 compared with a mean of 0.6 for patients with good renal function. My next question to you reads, are the pharmacokinetics or pharmacodynamics of other narcotic analgesics altered in patients with renal insufficiency? Next we will look at morphine. The pharmacokinetic disposition of morphine does not appear to be altered in patients with renal failure. However, its active metabolite, morphine 6-glucuronide, as well as its principal metabolite, morphine 3-glucuronide, do accumulate in renal disease. The elimination half-life of morphine 6-glucuronide increases from 3 to 4 hours in normal subjects to 89 to 136 hours in subjects with renal failure. This metabolite penetrates the blood-brain barrier more readily, has a greater affinity for CNS receptors, and has analgesic activity that is 3.7 times greater than morphine. Therefore, accumulation of morphine 6-glucuronide may be responsible for the morphine-induced narcosis reported in patients with severe renal disease. Let's now discuss codeine. Other analgesics that have been associated with CNS toxicity in patients with renal failure include codeine, propoxyphene, and dihydrocodeine. The disposition of orally administered codeine does not appear to be altered in renal failure. However, there have been case reports of codeine-induced narcosis. Although the dose of codeine did not exceed 120 mg per day, CNS and respiratory depression persisted for up to 4 days after discontinuing codeine and initiating naloxone administration. The elimination half-life of codeine is prolonged in patients on chronic hemodialysis. Although the volume of distribution of codeine was twice as large, the total clearance was not significantly decreased. A lower initial dose should be used because codeine is metabolized to morphine. Next we will discuss hydromorphone. Hydromorphone is metabolized in the liver to hydromorphone 3-glucuronide, dihydroisomorphone, dihydromorphine, and small amounts of hydromorphone 3-sulfate, norhydromorphone, and nordihydroisomorphone. All metabolites that are eliminated are excreted by the kidneys. Hydromorphone can be used in patients with renal failure. However, smaller initial doses may be warranted. Because EFG is not ambulating well after her surgery, her physician would like to initiate deep vein thrombosis prophylaxis with enoxaparin. So my question to you reads, are there any dosing considerations for enoxaparin in this patient? Enoxaparin is a low molecular weight heparin that is used to prevent and treat various thromboembolic disorders, such as deep venous thrombosis, unstable angina, and non-Q wave myocardial infarction. The kidneys play a major role in the clearance of enoxaparin, and a higher incidence of bleeding complications is associated with the use of enoxaparin in patients with renal dysfunction. The elimination half-life of enoxaparin is prolonged in patients with end-stage renal disease, although the other pharmacokinetic parameters are similar to those in healthy subjects. The increased incidence of bleeding complications cannot be completely attributed to pharmacokinetic changes, but may also be related to the effects of enoxaparin on antifactor IIa and antithrombin 3. As well as the effects of uremia on hemostasis. Enoxaparin should be used cautiously in patients with a creatinine clearance less than 30 ml per minute, with a recommended lower dosage of 30 mg subcutaneously daily. Although monitoring of the anticoagulant effect by anti-10 or activity is not necessary in clinically stable patients, it may be warranted in patients with renal dysfunction as well as in those who have other factors that may increase the risk of bleeding complications. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 351.